series slightly later, but his operations he published and shared with, excuse me, with the world. So they say, of course, it is not who does the operation first, but it is the person who teaches the world how to do the operation who often deserves the credit. But clearly, both of these surgeons were instrumental in making this an operation that you and I understand and can do today. Now, what I would like to do is just in a few minutes remind you of how these operations have changed over the years. I am relying on a nomenclature or labels that were created by not Dr. David or Sir Magdi Yacoub, but Craig Miller of Stanford University, who wrote an article which talked about how these operations have changed, and he gave numbers to these operations, David 1, David 2, David 3, up to David 5. But Dr. David never numbered his operations. These were labels given by Dr. Miller, and they don't even describe in the order of time how these operations evolved. But it's still a useful way to think about how these operations have changed. Now, the David 1 operation is also called the reimplantation. And as you know, in this operation, a Dacron tube is placed around the aortic valve after the sinuses are excised. There's often that small notch made here to make it easier to seat the graft at the commissure between the left and right sinuses. This operation was useful because it completely enclosed the aortic valve, it stabilized the annulus, and it was actually more hemostatic than many other operations because the suture lines are inside the graft. As with any other root replacement, the coronary arteries are reattached and an end-to-end anastomosis performed at the top. When these operations were first employed, there was a David and Feindel formula, as well as some other formulas for choosing the graft size, which in retrospect we think now may have been a little too small. And some of the patients who had these operations had injury to the aortic valve from the leaflets hitting up against the graft. And there were reports of the leaflets becoming thickened and retracted and aortic regurgitation developing. Now, the David 2 was an operation that could help prevent that by creating sinuses. This, of course, as you know, is called the Yacoub operation. And in this operation, the Dacron tube is cut with 3 tongues that were sewn to the annulus. But this operation, although it created a nice normal shape with sinuses, did not stabilize the annulus. And this became a problem in many series because even though it looked better, it looked more natural, in the younger patients with connective tissue disorders, the annulus would continue to dilate and the valve became a leaking valve. Dr. David noticed this in his series, as we did in our series at Johns Hopkins, and he tried to stabilize the annulus with either sutures or bands of pericardium or Dacron. And we also did this in our Marfan patients, but found that it was not effective. It did slow down the dilatation, but it did not completely prevent dilatation. I will talk at the end of this lecture about some of the newer ways of stabilizing the annulus in the setting of a Yacoub, but this is an old idea that is being revisited. The David 4 was an operation that would take a reimplantation with a large graft, but plicate it at the base and at the sinotubular junction to recreate the sinuses, but provide annular stabilization. This involved a lot of plicating sutures at the top of the sinus and at the bottom. But this was made easier then by taking 2 separate grafts, a larger one for the sinus and a smaller one for the tubular part, and this became the so-called David 5, or the Stanford modification of this. There are other techniques. Professor Takamoto at the University of Tokyo had a different way of plicating the sinotubular portion here, and Dr. Gleason at the University of Pittsburgh also had these very complicated mathematical formulas for creating the sinuses, which are still used very, very effectively, but they are complicated and they require some experience. We found it easier to use the Valsalva graft, a graft which already has sinuses preformed. It has a collar at the bottom and a long tubular part at the top. This was developed by Ruggiero de Paulus in Rome. His wife is a fashion designer, and as he was talking to her about how he should design the graft so that it could bulge out at the sinuses, it was his wife who said, well, this is the problem of designing a skirt, a woman's skirt, and that if you have the pleats or the corrugations running up and down, then it can balloon out. And so he used that concept to design this graft. This is a gelatin-impregnated Dacron graft, and I hope many of you know that with a gelatin graft, as opposed to collagen, you must be very careful to never use the cautery on it if it is dry. If you touch this graft with a hot cautery and it is dry, is not wet, it can catch fire. And this is a bad thing in an operation. So if you use this graft, you either have to cut it with scissors or wet it with saline and then use the ophthalmic cautery. The graft comes in sizes from 24 to 34 millimeters. That is the width here and the width here. The height of the sinus segment, the height of the sinus segment is always the same as the width here. It is a 1-to-1 ratio. And when it is under pressure, the diameter of the sinus is 20% greater than the width of the tubular segment. But we find that it does simplify the operation, and there's a lot less measurement and plication that needs to be done. Let me show you a few slides of how we developed a simple technique for this operation at Johns Hopkins. We begin by transecting the aorta above the sinotubular junction, and we look at the valve and we decide how the valve is closing. If the valve is already closing in what we call the position of prayer, and the valve is competent, but if it closes in this position, then we don't want to change that. We want to preserve that. So we measure the sinotubular junction diameter using a valve sizer, and we say this is the best or the optimal sinotubular junction diameter. We don't want to change that. We don't want to make it smaller, don't want to make it bigger. We want to preserve it. You measure that with the valve sizer and add 3 or 4 millimeters to it because the graft is going to sit outside the valve tissue. And that's how we choose the graft. Now, if the valve is leaking because of the aneurysm, then you can put stay sutures on the commissures and bring the root in to that point at which the valve closes properly. And that is the optimal sinotubular junction diameter. You add 3 or 4 millimeters to that, and that is your graft size. We excise the sinuses, mobilize the coronaries, and we place only 3 subannular sutures. They're usually pleated 2O polyester sutures below the nadir, or the bottom of each of the leaflets. These are sutures from the inside out through the left ventricular outflow tract. And these sutures are then passed through the base of the Valsalva graft. We trim the graft to only 2 or 3 rings at the bottom and about 6 at the top. We lower the graft down, tie the 3 sutures at the bottom, and then we attach the top of the commissure to the sinotubular ridge of the graft. There is very little judgment about where to put the commissures, how high. You just put them at the sinotubular ridge more than 95% of the time, and that is at the correct height. We tie those sutures at the top, tie the sutures at the bottom, and then run the hemostatic layer from the inside. This is usually a 4O proline. We start at the bottom and sew continuously up to the top of the commissure and then bring the suture out. We usually do the left sinus, then the non-coronary sinus, and finish with the right. And the sutures, 3 separate sutures, are tied on the outside. And this is what it should look like, with all 3 of the leaflets at the same height, and with a good area of apposition. The coaptation is in the middle of the sinus, not down at the bottom, not up at the top. So this just shows how with the Valsalva graft, the aortic valve sits entirely in the sinus segment of graft, and the closure is the position of prayer. Many surgeons who are starting this operation wonder what is the best way to choose the graft size. I just showed you one technique which is based on the sinotubular junction, and I can tell you that most experienced surgeons with this operation do the same. They say an eyeball technique to see where, at what sinotubular junction the leaflets come together. But there are other ways. You can measure the free edge length of the valve. That is the diameter. And you can measure that and add 3 or 4 and use that as the graft size. And El Khoury in Belgium also describes measuring the height from the bottom of the sinus to the top of the commissure in the left and non-coronary commissure. If you think about it, this is saying that the diameter is the same as the height of that sinus. It's the same 1-to-1 ratio of the Valsalva graft. And at least in North America, if you are trying to decide between 2 grafts, always choose the bigger one of the 2, because you can plicate a graft to make it smaller, but you cannot make a graft bigger. And if you really cannot figure out what size to use, at least in North America, a 30mm graft will work for most patients. I imagine in Asia it might be one size smaller. Now let me show you a video. This is not my video. It is by Dr. Chen, Ed Chen, in Atlanta, but it is one of the better surgical videos that I have seen, and he and I do the operation in a very, very similar way. It's just a 4-minute video, but I think it does show the technique well. So he has transected the aorta above the sinotubular junction. He's excising the coronaries and mobilizing the coronary arteries, and I'm sure you do this very, very similarly. Very careful in this part here not to undercut the undersurface of the left main, and you can free the left main from the undersurface of the right pulmonary artery to widely mobilize it. Now he puts a coronary perfusion cannula in there. I just do intermittent cold antegrade cardioplegia. And here, mobilizing the right coronary artery. Now he based his graft size on a measurement of the leaflets, which you'll see in a second here. By the way, when you mobilize in this area anteriorly, be careful. The AV node is very close, and if the cautery is set too high, you can burn the AV node and create heart block, especially in children, where that distance is very small. This area, mobilizing the right ventricular outflow tract from the sinus here, is sometimes very challenging. Sometimes the sinus is deeply buried in there. If you have suction on your left ventricular vent, you will see the leaflets coming together nicely. And here he's measuring the height of the leaflet with a ruler. This is Hyrone David's original formula. You measure the 3, you take the average, and then there's a formula where you can then choose the graft size. Dr. Chen uses the Valsalva graft, but when this video was made, he was still doing kind of like a David 4, plicating the graft at the bottom and at the top. So he uses, as I do, just the 3 sutures underneath there. Here, In the right sinus, it's important to make sure if there's any muscle bar there that these sutures are well below that. Those 3 sutures are passed through the base of the graft, and the graft will be lowered in a moment, and then those subannular sutures are tied. You can put more sutures in. You do not have to use just 3. But if you do the 3 in the beginning, lower the graft and tighten it, then it's actually easier to go back and put the additional subannular sutures in and follow the annulus up so that it's not all just in one plane. Here he is attaching the commissure to the inside of the graft, constantly checking that the leaflets are all at the same height, which you can see here is very, very nicely achieved. There is now the hemostatic suture line that includes the sinus remnant and the annulus. He is doing this inside and outside, but we usually just sew only on the inside. I think it is simpler, it's faster. And if you pull up on the commissure as you're doing this, it turns the curved suture line into a straight one and allows you to sew much more quickly. These are operations I think are much better to do with 2 surgeons, with each surgeon doing his or her side of each of these suture lines. And it is important to make sure that there are no gaps or folds here. If there are, there will be bleeding between the valve and the graft. The blood comes out through the bottom of the graft. But if you take your time and make sure this is a flat, secure anastomosis, this becomes very hemostatic because the blood is pushing the tissue up against the graft. Here he is using that ophthalmic cautery to create the hole for the left coronary. Here a standard anastomosis of the left coronary, which is almost always in the middle of the sinus, in the left sinus. But as you'll see, with the right coronary artery, as in most aortic root replacements, it's better to put it higher and more in front anteriorly to make the right coronary less likely to kink or be under too much tension. The rest of the operation is the same. When you do severe connective tissue disorder patients, there is sometimes some value in reinforcing the anastomoses with felt. Now, when you resuscitate the heart, you need to evaluate for residual aortic regurgitation. And as you know, there can be problems with this operation. If the annulus is too dilated or the sinotubular junction too dilated, as in the graft being too large, or if the nodules of Aurantius are very thickened, you will see a regurgitation jet that goes straight back into the left ventricular outflow tract. But if you see the regurgitation jet is eccentric, going either way, just as with mitral valve surgery, this suggests there is leaflet prolapse. And the regurgitation jet usually points away from the prolapsing leaflet. If you identify a prolapsing leaflet, you can either plicate the leaflet in the middle of the sinus or run a suture that goes along the free edge and then comes out outside the aorta and tied to lift the leaflet up. But many patients with severe connective tissue disorders, the leaflet edge is too thin. So for the most severe and the youngest patients, leaflet plication, I think, is better. Just to remind you that if the nodes of Aurantius are very thick, and that's part of the reason for the leakage, because they will not close in the middle, you can do a leaflet plication that folds into the center rather than away from the center. And that little node, that thickness, will fit into that gap just like a key fits in a lock. These are probably usually not very large holes for regurgitation, but it will make it look better on the echo. So now let me talk about the results of valve